My dear friends, I'm here again with you. You know, before we started here, I was commenting with my colleagues here. We have a group, we have a great team working with us, that this is the way I feel better when I'm in a classroom, when I'm teaching, you know, because this is something that is in my spirit. Being with you is for me something else. So I thank you all for being with me today, and I appreciate all your comments. If you comment in our chat here in YouTube, what you feel about it, what are your doubts about orthodontics. I will try today to tackle all the doubts that I usually have from my students. Not all the doubts, of course. Of course, can't do that because there are so many doubts in our daily practice, but we can address some interesting topics that are generally something that we are not thinking about. And those things may end up being very bad in our mechanics. This is what I want you to do now, to pay attention to that. This is what we call the 3D Ortho Biomechanics Week. Why? Because I want to show to you in a 3D way how we can do things better in our practice. I struggled for a long time. I'm going to tell you something about my own story. I struggled for a long time to understand biomechanics. And when I was, because I'm very visual, when I was in my journey to understand biomechanics, I stumbled with very good things, very good articles and textbooks, but mainly to the images that wouldn't really help me understand better biomechanics. So that's why I did it my own way. I started doing this type of drawing. I started very simply, actually. That was like a 2D drawing. But in my mind, when I saw that, I could understand better. When I did the movements, I could understand better what was going on with my own cases. And now I'm bringing that to you. The evolution of several years of teaching orthodontics from the 2D to the 3D, and also by emerging, by delving into this 3D type of knowledge of showing things to my students, I started learning by myself biomechanics in a different way, completely. Why? Because I could see that, well, there are some things that are not really helping me, that are not really working in my daily practice, and this is something that I can change. 3D Biomechanics Week is about that. So during this week, you will learn how to master biomechanics in a simple and practical way through 3D visual content and achieve better and faster orthodontic treatments. Yes, of course it is possible. Yes, of course it is achievable by anyone, by each and anyone that's going to apply this type of method. Why? Because I see that every day. More than 2,000 students nowadays showed me that it is possible for everyone to apply this type of concept, and faster, in a simpler way. I'm going to show to you during this class how I think about it. And you will get results like this. You're going to do this type of treatment in which you can and will do this type of mechanics very fast, even without extraction, even without the need of doing specific distalizations. You are going to see that it can be simple. It will be simpler to you if you apply the protocols, if you apply the method. Don't miss out. Orthodontics is not about fancy devices. It's not about something very special. I don't want to teach you by putting things very difficult, blocking your knowledge and sending to and trying to sell to you facilities, easy things to do. No, I want you to do the way I teach my students. You know what drives me nowadays? Seeing people and watching cases in Instagram or wherever, and with people that are applying my method and telling me, Prof, you can call me Kleber, I'm your friend. Prof, I'm doing this better now. And it's simpler. And it's easier than I thought it would be. I promise you, if you apply the method, I promise you, if you do this way, you're going to do things faster and you're going to end up with better results, for sure, okay? So you can do things like this. I'm gonna show this case during this week. You can do things like that using, for example, what I called in the past something a Centrex that I have the patent of it. Nowadays I do differently, but the concept is the same. And I have something that I saved for a near future that will help you a lot also with biomechanics. Based on that, on this type of concept. This is the Centrex system that will apply the line of action of the force in the level that we want. So you can use this type of concept. You can do distalization in 2 stages, distalizing the molar with mini screws as anchorage and using special loops. This loop I designed like by chance when I was in a class with a student of mine, telling her, look, we're not really doing the right thing here. It's not going the way we think it is going. And why don't we apply our biomechanics and try to be more creative? Creating a loop that will be designed for this case, and this case is going to be faster, and this case is going to be much, much more precise in the distalization, okay? So let's do this way. You are going to learn also this. And this is the loop that I created that day, and I will use this loop in several situations. You're going to learn also some types of different loops, like for example, the delta box. You know, when we apply this, when we compare, there are several other ways to do that. Yes, there are. The ways that we have to do that are not better or worse than this. This is just a loop, and the loop is based on solid biomechanics. If you understand that, I promise you guys, I promise you, there is a moment that you see that you cannot unsee it anymore for life. So this is what I promise to you. I promise to you. You're going to see the right way to do that. And once you see that, you're going to create wonders in orthodontics. Stay here. So we're going to also fasten up our mechanics. Why? Because we are going to understand the wrong way to do things, and what really makes our treatment longer is our own mistakes. We do that every day. We do that every step of the way. Why? Because by not knowing the correct biomechanics, when we apply some type of mechanics, I'm going to show to you during this class, because this class is about mistakes. And you are going to see that probably you are making the same mistakes in your daily practice. And I'm going to show to you when you do that, you're doing the opposite that you want to do. This is common sense biomechanics. You do something thinking you're doing that wrong because maybe you were taught this way. Maybe you think that visually saying it makes sense. But in fact, it doesn't make sense. But in fact, you are not doing what you want. Why? Because the biomechanics is against your planning. That's how we do things faster in orthodontics, by avoiding the mistakes, by avoiding the wrong way. The method you see here is the result of extensive academic and scientific research work. Guys, 27 years now, giving classes, 27 years now in the field, seeing what's wrong, understanding the problems, going through the science, research, publishing, and all this helped me to help many people, as I'm going to help you, for sure. Over 27 years, I'm in depth studying biomechanics, and this biomechanics that you're going to see today is no different from any biomechanics. I'm just showing to you how it's helping me and how this method that I developed is helping people all over the world, orthodontics like you and me, okay? And intense clinical practice, I have over 5,000 patients treated until now, And because of my own mistakes, because of my own correct things that I did in my office, I managed to create this method. I managed to create a new protocol for each case that will really help you a lot, okay? The same method responsible for bringing results not only to me, but to thousands of students around the world. Look at what they have to say. Well, I'm doing that for a long time. And what people are saying about it? What's happening? Unlock the path to innovative or accuracy.
Well, I'm glad to be part of this course. And also, I must say, even biomechanics is so much complicated for us, the beginners. The professor explained in such an easy way, so it's not possible not to understand, and you can practice it from it.
Good students.
Now.
Meireles is amazing. The treatment time that we see here,
Mano,
it's amazing.
meu pai tá me ligando desesperadamente. Liga pra ele, por
We
favor.
are amazed by the protocols that Prof uses and the way he levels the curves of speed, he distalizes, he corrects the asymmetries, how he deals with the vertical dimension.
Always delta loop.
I would like to thank Professor Kleber for his orthodontic course. He was very helpful and very important to know everything, every situation you will face in orthodontic situation.
Thank you very much. See you again.
Oh, my friends, you don't know how it means to me. It means the world to me, you know. When we see cases like that with people saying that, well, I'm doing the right way now. I'm doing that because I learned from you, and I learned from good masters. Everyone in the world needs a mentor. We need a mentor. So I had those mentors before. I had those good professionals, good orthodontists that taught me the right way. Some of them, the way they did, and I adapt, and I added to those knowledge, other knowledge that helped me a lot. So this is what I'm doing now. I'm passing along. I'm doing the same thing for you. So before we begin, I need you to do some things for me. And I need to read it now because my memory is not that bad. It's not that bad, but also I have many things in my mind. Have something to take notes with, whether typing or using a notebook or any paper. So have something so you don't miss out the knowledge that you're going to have now. Pay attention to everything you see. When you think you already know something, pay even more attention because that's when the best insights, they emerge. Close all tabs and focus completely. Of course, you can't like do that. Go to a class like this with that knowledge with a TV turned on. Not possible. Just pay attention. Just pay attention. Okay, do your part, I do my part, okay? Just pay attention. Grab a headache pill because, this is a joke, but of course can be. Your mind is going to explode, to blow up from so much learning. I'm just kidding, guys, okay? Comment in the chat. Yes, please do that for me. Do that for me. It's a beautiful when you see that in the chat. Hashtag I am 5% to let us know you are with us in this movement. And you know why we are calling this? I'm going to show to you why we're calling this. Hashtag I am 5%. I am 5%. You may be within this 5%. You can be the one. You can do things better, and you're going to achieve direct payment for that, for being a better orthodontist. And you are going to be in this movement. This is all about you. All about you, okay? How did this method came about? This is why we're calling that I am 5%. Our data, meaning we've been doing that for a long time now. We've been doing that for like some years. And in recent years, let me ask you, we have over, Maurício, probably 5,000-6,000 answers like that, huh? Yeah. In our, yes, we have something like that. This is just from this event, 2,000 answers. You know the question, how confident do you feel regarding biomechanics and orthodontics? Completely confident is the blue one here, just 4.2%. 4.2%. And orthodontics is about biomechanics. If you're not confident in biomechanics, you're really not doing orthodontics. You're just doing the sequence of arch wire. You're just doing what the companies are telling you what to do. You are not really doing your orthodontics. Something else orthodontics you're doing. We may not even call that orthodontics. Treatment, dental treatment for aligning teeth. Aligners do that. Not bad. Aligners are not bad. They are very good, but they have their problems. So only 5% of this is a huge number. Over 6,000, 7,000 people answering, all the time is the same, all the time is the same. Only about 5% maximum are really completely confident about what they're doing, biomechanically speaking. That's why we are saying, I am 5%. You can be within this 5% of people that are really confident on applying the biomechanics in a daily practice. The main factor that causes insecurity in orthodontists is the lack of mastery of biomechanics. We are saying that now. So we are just doing that. And a long time ago, when I was doing my own orthodontic treatments in my office, I started stumbling in some difficulties. Those difficulties showed me the right way. Those difficulties made me stronger. You know, I didn't give up. I never gave up. What did I do? I delved much deeper in the knowledge because I was not accepting to create my own malocclusions. And that's what I was doing at that time. I was doing something, but by doing that, not knowing the correct biomechanics, I was generating other problems. And those other problems, they were elongating the treatment time. They were making me uncomfortable with the outcomes. What did I do? There's something wrong. I must understand better biomechanics. I must establish some types of different approaches so I can really overcome those problems even before they arise. And I did that. Why? I understood the problems. Taking pictures, going deeper in the study of biomechanics, going to courses, asking my mentors. So, but because I did that, I managed to create this protocol. And what I'm trying to do here now is to say to you what is the right way to avoid the mistakes that we are really applying in our daily practice without knowing and that are compromising our treatment outcome. And this is what I'm going to show to you today. Of course, we can't show all the problems, but by showing some problems that you're going to see and recognize that you may be doing the same thing, you're going to understand there is a better way to do that. There is a better way to do that, okay? So that's why we are here now. We want to be in this 5% of completely confident orthodontists. And that's why we are going to show to you this. There is a simple and practical way to master biomechanics. I have developed, you probably know that I'm doing that for a long time now. So you probably at some point saw some kind of content of mine with the 3D images and 3D way of teaching. And this is the way I myself understand orthodontics. Three-dimensionally, I can understand better what's going on. When I see a bidimensional image, for example, I'm giving you just a simple example. I'm trying to do the distalization of the lower arch. And I saw in my panoramic X-ray that I have the third molar that I'm going to do the extraction of it. And by the panoramic X-ray, a two-dimensional image, I see that I have enough bone distal to the second molar. But what's going on in the depth of that bone? You know the cortical plate of the outer part of the mandible, in the body of the mandible, sometimes it's so close to the root of the second molar, distal root of the second molar, that won't allow you to distalize, the second molar. But you saw in this two-dimensional image that was possible. Three-dimensionally speaking, you are wrong. Just a simple example of that. So by this, I can teach you better. I delve into that to give to you a three-dimensional way of saying that. Many people ask me, you know that, many people ask me in my daily staying in Instagram. People ask me, Prof, I want you to tell me, how can you do this type of video? You're doing some videos that are very good. And I tell them what I did. My path for being here, showing to you this content was, I really needed, because I was paying like thousands of dollars for having one video, 1 minute video. Now it's wrong. And it was not good. I was not really satisfied with the outcome of that video because I needed to be with the 3D professional to do that with him. I was not satisfied. What did I do? I started learning the 3D in my daily studies. First of all, I started with the 3D, 3D from the Autodesk, 3D S Max. Yes. And I could like model my teeth, model my brackets by myself, and then I use for assembling that, the PowerPoint, the Keynote, and then I went to the Final Cut. So I have several programs that I use nowadays to give to you this, the 3D image. Let me give you an example of that. For example, very simple. I want to show to you what's the correct way to position a molar or a premolar, and I'm going to show to you in this beautiful image. It's also an image that I created, but I can do it better. I can show to you that there is another way to view, for example, this. The mesolingual cusp of the maxillary first molar occludes in the central fossa of the mandibular first molar. Let's do it. Look at that. Now you see where it is. Now I can change the view so you can see closer the right position. This is completely different from just a drawing, okay? So this is the way I do my own stuff for understanding better and for passing to my students this information. You see, orthodontics is three-dimensional, not bidimensional. So we need to be three-dimensional in the way we teach our students. I want to show to you that if you apply a different torque, I will have a different outcome in the relationship between the cusp and the fossa of the lower molar. How can I do that? Just saying, no, you're not going to see. The way to see is this way. You see now the couple, you see now that we have a movement different from what we want just because you missed the right point of bonding your tube in a situation like that. So we have several ways to ruin our treatment. And if I explain to you this way, you are going to anticipate the problems and you are going to avoid them because you know that by doing that, you're going to do a faster treatment. Today in class 1, we will talk about no more insecurity, how to avoid several common mistakes made by orthodontists in their daily practice. And we start now with our class. Thank you for being with me. I will start with the explanation of how several situations can help you because you're now going to avoid the mistakes. Let's see just class 2. Just class 2. Remember, 55% of our patients are class 2. And you're treating your patient how? Oh, Prof, let me show to you class 2 case. Sometimes people don't even send the image for me. They say, I have a class 2 patient like a 4 millimeters over jet, and the patient is 12 years old. Where is located the problem? Maxilla, mandible. Is your patient hyperdivergent or hypodivergent? Is it a growing patient? What are the numbers of cephalometric analysis that are going to help us? This is everything about three-dimensional analysis. And I'm going to show to you how. For example, what's the most common way to treat our patients, our class 2 patients? What's the most common way to address a class 2 situation? Is by distalizing upper teeth. Well, we know that only 15 to 20% of our patients, they have maxillary protrusion. Huh? The other part is maxillary plus mandible. 60% of our class 2 patients, they have deficient mandible, but we are treating them in the maxilla. Yes, we need, because we are not doing magic in our practices. If our patient, they have the right profile, they have the right facial pattern, we can do that. Even though we know that the problem is in the mandible, in some cases we can treat in the maxilla, because we are putting it on a scale, and when we put it on a scale, what we did for our patient to increase the beauty is more than what we did to really jeopardize some type of beauty or profile or something, okay? So take care, because this is not about what I want to do. It's what the case tells me to do. What the case is really asking me to do. Let me give you an example that is very common. Class 2, 55%. Among class 2, what is the most predominant profile? Class 2 Div 1 or Class 2 Div 2? Class 2 Div 1. Hyperdivergent patients, especially here in Brazil and many countries that I visit, they are this. Class 2 Div 1, patient with lower anterior face height increased. And let me just show to you one example that shows the importance of understanding, fully understanding everything about orthodontics, fully understanding everything about diagnosis. What is your patient? Class 2 is a detail of it, a minor detail of it. Look at that. Follow with me. This is Class 2 Div 1, clockwise rotation of the mandible, excessive gingival display during the smile, increased lower anterior face height. And you're treating how? I'm treating nowadays with a very fancy device, Kleber. Why? Because now we have the beautiful IZCs. IZC is anchorage. Anchorage is not treatment. The choice of the anchorage that you have, IZC, let's say even headgears, or nest button, or elastics, they are together in this beautiful spot that we call anchorage devices, okay? Anchorage is something that you're going to apply to achieve the result that you want. And now I ask you something. I'm going to give you just these options here. Put it on a big screen so they can see. 1, 2, 3, 4, 5. I have 2 more options to show to you. 1 is elastic. 2 is distalizing with extraction plus TED. What's the height that you're going to put the line of action of the force? Do I really need TED for that? I can do that by means of losing anchorage. What's the explanation of that? What's the mechanics behind that? What's the indication for that? You see, it's crazy. It's crazy when people send me an image of the occlusion and ask me, Prof, what can I do in such case? I don't know. I'm not a magician. I can't do magic in orthodontics. I can do science in orthodontics, not magic. So what are the options that we're having here? Let's say elastics, Class 2 elastics. Are they good? Class 2 elastics, wow. Maybe the most simple device, maybe the most common choice amongst orthodontists, but something that really can be very bad in a Class 2 Div 1. Because when we do that in a Class 2 Div 1, let's go to the 3D content so you can understand it better. We are treating the occlusion, but the occlusion is a detail of the mechanics. The occlusion is something that we are treating together with the face, together with the TMJ, together with several variables. are we really doing the right thing in a patient like this? When we do this, we understand that we want to distalize the upper arch because we can't mesialize the lower arch, even if, let's say we can, in some cases, the growing patients. Okay, there is the right indication for that we're not tackling today actually, but there is a right indication for that, which is not this one, not vertical, never vertical. And if the patient is vertical and you want to correct the class 2 by means of distalizing the upper arch, you are paying a very heavy price, very high price for that. What is this price? You are increasing the lower anterior face height because of the rotation, the clockwise rotation of the mandible. Did you want that to happen? Not in a class 2. Not in a class 2 div 1. Because in a class 2 div 1, when we do that, you do the correction of the occlusion by means of rotation of the mandible down and backwards, and it will increase the facial convexity. It will increase the dental exposure in rest lip position, not really rest lip position, because you're going to increase the lower anterior face height and you may end up not anymore with a passive lip ceiling. Passive lip ceiling may be lost because of your mechanics. So this is wrong. Class 2 elastics are not indicated for vertical patients. It will make them more vertical. Further rotation of the mandible down and backwards. And you know that some patients like this, they have really a very big lower anterior face height. And this is not what we want. What are the options if we don't use elastics? Let's say I want to treat my patient with extraction plus distalization of the upper anterior teeth. Look at that. This is completely different when we compare with the distalization of the entire upper arch in one piece at once. We are not doing this now. What we are doing now is the correction of the class 2. The class 2 in K9, just think about it, the K9 relationship by distalizing anterior segment. But do we really need to use TED for that? Do we really want to do the distalization like this? And do we really achieve, look at so many questions. And do we really obtain this type of movement with this type of mechanics? Well, I don't know, and you don't know. You want to do this, you want to distalize an upper arch by using the line of action of the force at the center of resistance of anterior teeth. We know that, in average, the center of resistance of anterior teeth is approximately 10 millimeters high in relation to the center of the crown of the anterior teeth. And if we do that, we are trying to do a translatory movement, bodily movement. Bodily movement is what we aim at. But are we really doing that when we do this type of mechanics? What we think we are doing is this, but there is a flaw in the system. This is something from the previous class. I'm going to go faster because I want to go to other knowledge in this class here, but you already know, guys, that because we have a play inside the slot, we are not really attaching together the entire upper anterior teeth from K9 to K9. We have several bodies being pushed with one point of application in the center of the crown. Why? Because we have this play inside the slot that will generate the well-known roller coaster effect. And if you allow the roller coaster effect to take place in a patient like that, you're increasing the gingival display during the smile. You're increasing something that your patient probably was complaining before the treatment. You're worsening the problem. Good? And let's say, okay, I know now. Okay, let's do the right way. What's the right way? I want to apply the mechanics with a torque or with a thicker arch wire to really control the inclination of anterior teeth, because I know that if I do this way, without a torque, without a thick arch wire, I'm generating 0.00001 inch of difference between the height of the wire and the slot. This is the plate that we have. That will give me 20 degrees of loss of inclination. Crazy, huh? This is a biomechanics? No, this is simple chance. We're pushing and trying to do the right way. We're doing this and trying to do the right way. It's wrong. But let's say we do the right way. We apply a thicker arch wire, 2125, almost no gap inside the slot, and we really ligate all anterior teeth together in a very rigid ligation, what we want. Still, not the right way to do this in this type of treatment. Why? Well, because you're going to do this. You're going to do the retraction of anterior teeth, and in this case, you don't even need to contact anterior part to posterior part, because this is the body that you're moving, anterior teeth all together, a new body, and if you pass the line of action of the force bilaterally at the center of resistance of that body, you're translating the body. You're doing the pure translation, theoretically, of course. Orthodontics is not like that because we must adapt. But this is the case that I treated this way. There was an indication for that. In this case, there was a patient, this was a patient with normal facial pattern, not hyper, not hypo, and there was good indication for doing this in this type of facial pattern. But not here. Not here, you know? Why? Because you want to decrease the lower anterior face height, and you are not decreasing the lower anterior face height this way. You know what? Actually, you're increasing it. You're increasing it, okay? I see that we have now 1,400 people live. Please call your friends. Tell your friends, call them, come here, good information. Do that for your friends. Please go to Instagram, to Facebook, call someone. They're going to be here with us. Give them the link. So what we have here is this. We are doing the distalization, and at some point we have a class 2 half cusp. Why are you using this? Because you need to lose the anchorage. You're not going to give a full distalization to end up with a class 3. In a class 2 half cusp, you need half of the movement from distal to mesial and half from mesial to distal. And you do that by not using anchorage. So this is the right way to do that, okay? Guys, and that's the second option. Let's say I will not use this type of mechanics with a high hook. I will use a low hook. Now, the play is going to be different, harder. How come? Because now you're generating a moment, and you already know that. The line of action of the force is below the center of resistance of anterior teeth. And now, because the force is applying at that height, you're also generating a moment which is, in this sense, a clockwise moment. Now is not a kid's play anymore. It's an adult play. We must add to the system another couple. What is the couple? The couple, the moment of the couple, to counteract the moment of the force must be applied this way, by generating the couple inside the slot. Torque. And you know, I know, everybody knows, torque is different. Torque is not easy. Torque is very difficult. How much is the force for in-mass retraction with TADS? 350 grams per side. Maximum of force if you are applying the friction mechanics, the sliding mechanics, okay? Biomechanics for unilateral scissor bite correction. Well, this is something different from this class. I'm so sorry for that. We can't go to all the doubts because we must focus on the topic of today, which is class 2 and class 3 closing space, okay? I promise to do that in other classes. I will be here for you. My team here is taking notes. They are taking notes about what are the most common doubts, and of course you're going to do that in another class. So we have now something difficult, and when we do this type of mechanics, guys, we must also control the posterior segment when it is retracting, because there is a tendency of losing angulation that will end up rotating the mandible backwards and downwards again. Not the best mechanics, not the best mechanics with that list of problems. That's not what we want. Let me just give you now a hint. Let me just give you what we want. What we really want is the splint effect. Splint effect. We want something that will control the vertical, maxillary vertical displacement going up and distal, or even just up. In the next class, I'm going to show to you all the explanation why sometimes you go just up and sometimes you go up and distal. Don't miss out. I'm just showing to you the way. And if I'm doing that, look, I'm sweating here. If I'm doing that, I expect you to do that with me. Okay? Stay with me and focus on that. Please do that with me. What if we don't extract? Oh, now we're approaching the right way. Because when we do this way, why we don't extract in some cases? And there is a protocol for that also, you know? I'm going to explain to you also this. You can't do this type of mechanics without extraction when we don't have bone distal to the second molar. Don't try to do that. You don't know how to grow bone, I bet. I don't know. Only God knows. You don't know how to grow bone. Put it in your mind. Don't even try to do that. Don't believe when people say that we do that when you do very slowly. Don't believe in false prophets. They're selling you snake oil. I'm not selling you snake oil. I want you to learn just that. Pure and simple. What we are doing now. Two options. Wow. Somebody told me that there's a new device that I can put a high hook, because this high hook that I'm buying from AliExpress or somewhere, oh, it's magic. I'm putting the high hook now to distalize. Is it good? No. Terrible. What's the other option? Low hook. Is it good? Better. Better than the high hook. So you know, guys, when I'm teaching that like that with this type of passion that you're seeing, you see how I'm sweating here? The type of passion I'm giving here is the type of thing that I do when I explain to my own patients. Look, this is not possible. Look at this. This is what's going on. Because I see that a long time ago. And again, when you see that, you cannot unsee it anymore. You see that, well, there is a moment. There is the line of action. There is the need for doing this, the need for doing that. And you're going to see the right way to apply that. This is the wrong way if you don't want to extrude anterior teeth. You see, there's a difference. This is the worst thing that you're doing for your patient. Wow, come on, Kleber. I'm using the IZC. IZC is perfection. I'm using a good coil spring. I know that the rate of movement of the coil spring is higher than the power chain. Everything is perfect. How can you say this is not going to work? Because biomechanics, guys, it's not there for us to play. It's not kidding. Something serious. When you do that, you're generating a type of movement that maybe you don't want. We have different ways here. Look at that. We have line of action of the force below the center of resistance of the, look at the differences here, entire upper arch. And now we have the line of action above the center of resistance of the entire upper arch. But for us to consider that, the entire upper arch, I'm not doing that with night tie. I'm not doing that with 1725. I'm not doing that with a very low thickness arch wire. this is not going to work because you're going to create here again what you don't want, which is what? The play inside the slot. That will make mandatory for you to do the torque. Otherwise, you're going to lose inclination and also generate the roller coaster effect. So don't make it simple. Make it thorough knowledge about it, okay? Let me ask you something, okay? Because I know that you're here with me. Can you do a favor for me now? Like something that I need to do that because YouTube will read this way. If you give me a like now, YouTube will deliver this content to more people and it will help me increase the range of people that I'm really having. Let me just go further with this information. This is something that I'm asking you, just give me a thumbs up. Extraction pattern for class 2 div 1 with no crowding. Of course you can do that because you want to retract. You don't need crowding to do extraction. The extraction in this case is to correct the class 2 in K9. You do the extraction in crowding to alleviate the crowding, and sometimes to correct the class 2 also. But those are different animals. Crowding is one thing. Class 2 is another thing. So you can do the extraction in this. Even if you want to extract molar, in some cases, it is indicated, okay? No problem. I'm showing to you now this. Look at that. I will use the high hook, the high point of origin of the force with the IZC. What I'm going to give now to the distalization, a moment that is counterclockwise, and this counterclockwise moment is rotating the mandible down and backwards. Worse, much worse than before. Now you have two problems. You still have the class 2, and now you have a more vertical and higher lower anterior face height that you created. And now the treatment is longer. And now you need to do the extrusion. Maybe lower, maybe upper, maybe both. Not what you want. So you thought that was a good mechanics, but it was not. Let's say that you have the third molar, because you need a third molar here to extract and do the distalization of the entire upper arch in a very precise way, faster because of the rapid acceleratory phenomenon. But without the third molar, please think again. Maybe in the panoramic X-ray you have bone, but look at the CBCT. Let's say everything is all right. Don't apply a high line of action of the force. Because if you do that, you're rotating the mandible down and backwards because of the rotation. Let me go again. The rotation of the maxillary occlusal plane. And the rotation of the maxillary occlusal plane may be good for anterior segment, but it's very bad for posterior segment. Look at that. Rotating the mandible down and backwards. Okay? I'm going again. So this is not what I want, really not what I want, because it will make this gap, rotate the mandible down and backwards, not saying that it was not indicated because you had a good nasolabial angle before. So this is something that you must consider. Always, at all times, consider the diagnosis of each case and apply the right biomechanics for that case. Remember that I always say that. I always say that there is a tripod in orthodontics. What's the first leg of the tripod? Diagnosis. Second leg, what it is? Treatment planning. From the diagnosis. And for achieving the best result, in less time, with better results, we need the biomechanics. So the biomechanics itself, it will not help you if you don't understand the concept behind that, the 3D evaluation of the system. Let's go to the second option now. I do now the lower line of action of the force. It's good. At some point it's good. Why? Because the lower line of action of the force in relation to the center of resistance of the maxilla will intrude posterior segment. Intruding posterior segment gives space clearance, so the mandible is going to rotate up and forward. Huh? Completely different, huh? And this is going to increase the pogonium position. But there is a catch here. There is a catch here. By doing that, you're extruding into your teeth. Is that what you want? Maybe, maybe not. But this is the good part of it. Rotation of the mandible up and forward. For a class 2 is what we want, but not the exposure of anterior teeth. Now we go to, I showed you 5 options. For a class 2 DV1 patient with lower anterior face height increased. Look at that. You know the good part is if you understand the concept behind that, I don't need to go with thousands of options. You understand the concept. Again, you're going to see. Your eyes are going to be opened, okay? And now we have 2 other options. What if I control the vertical here and distalize? There is an indication for that. I can give 2 lines of actions, one distal, which is going also to intrude posterior segment because of the moment of the force, and I give another moment in anterior segment. Maybe a higher moment, I don't know. We are going to learn about it, okay? Not today, I'm going to show to you today the problems. So in this case, we have one situation that I want to have the splint effect, distalization plus impaction of the maxilla. This is what we call the splint effect. Or maybe I want just to do the impaction of the maxilla because I don't want to retract, because I have a good nasolabial angle. Completely different indication, completely different outcome. So you see, everything is based on the right diagnosis. So guys, this is the most common problem that we can see in class 2 DV1 patients, which is a very common situation for us to treat in our offices. And now we go to another example. Class 3 patients. And I bet that if I put it here now, because we don't have time, but if I put it here now, what is the thing that you need to avoid in patients, in class 3 patients that you are treating? You may think about device, you may think about bracket, you may think about prescription, but there is only one answer for that question. I'll give you like 30 minutes, 30 seconds to think about it, because I need to have a sip of water. Think about it. The answer is already in this class. Think about the lower anterior face height. You know, the only thing that you don't need, you can't have in class 3 patients is decreasing the lower anterior face height, because your patient is already concave, or at least with a flat face. If you decrease the lower anterior face height, what's going on? By the way, all those previous questions that I made are going to be answered on Wednesday. Because I need you to go to your home, I need you to close your eyes, think about everything, study a little bit, you can go back in the information and think about it. And then I will give you the right answer. In this case here, what we usually see in patients like this, tell me if I'm wrong, is because of the new mechanics that we have nowadays by using buccal shelf. We think that the buccal shelf is magic. Don't you think so? But it is not. It is not. It's quite the opposite. Quite the opposite. Buccal shelf is something that is just anchorage, and you're thinking about buccal shelf as the magic pill that will solve class 3 cases with prognatic profile. And pay attention now. If you're looking at somewhere, look at me now. Look at me. Let me talk to this camera now. Am I right? Yeah. Look at me. You are doing the wrong way. You are doing the wrong way because of 2 things that will really jeopardize the outcome of this treatment. Do you know? Two details. First one, the line of action of the force that you are applying here, when you use the buccal shelf, is usually the line of action that you are using above the center of resistance. Your patient's profile is like this. Low exposure of upper teeth, which gives this patient aging. It looks like someone that is 90 years old, because not showing anterior upper teeth. This youthness resembles youthness. This resembles aging, okay? They don't want that. You're worsening this. How? Because you just think about this bidimensionally. You think that you want to correct, it's very hot today here. You think you want to correct this here. The first detail is this one. The second detail, your patient, your patients, they don't have 10 millimeters distal to the root of the lower incisors. What are you doing? Distalizing 8 millimeters because a huge class 3, I saw someone doing that, I saw that on the internet. I call your attention now about one thing. Look at your case, look at the case that you see in the Instagram. Some people try to do that with buccal shelf, and they don't even engage the second molar. Take a look at the step between the first molar and second molar. Put that in your mind. You're going to see that. And when you see that, you're going to see the mistake. What's going on now? When we do this, by distalizing this type of patient, what they want is to increase the lower anterior face height. I'm going to show to you the protocol for that. And you're going to treat your case like this, half of the time. Because you're adding a magic pill. No magic pills, but you're adding something that can help your patient. I'm going to show to you on Wednesday. Look at that. What we are doing now, guys, look at this. This is terrible. We are doing the opposite that we want. We treated before, in the 80s, those patients. In the 90s of the second century. Why? Because we didn't have the buccal shelf. I'm not saying the buccal shelf is bad. It's beautiful. It's very good. The worst thing about buccal shelf, they don't come with a protocol. You don't know what you do. You just apply the force. In the past, we did it before. Why? Because we usually treated those cases with class 3 elastics, and they increase the lower anterior face height, rotating the mandible down and backwards. You are doing the opposite now. You're doing this. Let me go again. I want you to put that in detail. I'll put it in detail so they can see. Let me go back. Look, you had this. No exposure of the tips of upper incisor in relation to upper lip. And what you needed to do was this. And you're doing the opposite. You're doing the intrusion of posterior teeth this way. And you're rotating the mandible up and forward in a class 3. Not what you want. This is wrong. And you're forcing the line, the symphysis, the cortical plate of the distal part, the lingual side of the symphysis, is now being forced by the root. Now you have root resorption, bone fenestration. Now you have a mandible that's more forward, and it makes necessary for you now to do what? More compensation, less exposure of upper teeth. It's completely wrong. Don't do that. Let me give you another invitation. Go again to those beautiful cases that you see, beautiful in occlusion, with a very large distalization of the lower arch, and see if they have at least a cephalometric X-ray after. I bet those incisors, they are almost outside of the symphysis. If they show the face, you're going to see that the face now is worse because of the line of action of the force, because you didn't understand the 3-dimensional way of seeing orthodontics biomechanics. So guys, completely wrong. You end up with this, more concave profile, less exposure of upper incisors, more proclination of upper anterior teeth because you need more compensation. So everything is completely wrong. But there is a right protocol for that. Now, I'm not saying that I have the magic pill. I'm actually saying that there is a right protocol that we know about it for a long time. We know what to do. We are just doing wrong. I did it wrong. I had my share of doing many things wrong in class 3 patients. Rotating the mandible up and forward, because in the past, for example, like in the 2000s, we did that a lot. We usually, because of the new tool, I have my own problems. Because of the new tool that we had, which is the mini screws, we usually do it by closing the bite. We always use the same approach, intruding upper teeth, because now we can do that. Patients like vertical patients, we did that a lot, but when we have vertical patient and we do the same approach here you're doing, but in the upper arch, when we intrude posterior, you're just intruding the opposite arch, the lower. When we intrude posterior upper teeth, we rotate the mandible up and forward. By doing that, we are increasing the class 3. By doing that, we increase the need for compensation of upper anterior teeth. By doing that, we give instability to the system. So this is the same thing. Vertical in class 3 patients must be the opposite. You want to increase it. Prof, but you're saying that when I have a class 3 patient with vertical access, can't I intrude? No, you can't. No, you can't, because the mandible only goes up and forward. And I'm going to show to you on Wednesday. I'm going to show to you. So this is the wrong way to treat your patients. You're increasing the need for more compensation. You're increasing the need for doing other things to correct the malocclusion that you created by intruding posterior teeth in a class 3 profile. Not what you want. Not what you want. So guys, good to be with you until now. I'm gonna, yes, I'm gonna answer some questions. My team here is always attentive about it. But before that, I want to show to you our schedule. So on July the 2nd, review the recording of class 1. Enjoy reviewing class 1 to be even more prepared for class 2. So you have tomorrow to do that. In our hometown, it's going to be a holiday. So I'm going to prepare myself in this holiday so I can give you more energy in the second class. July the 3rd, we have on Wednesday, live broadcast of the class 2. Okay, so we have the class 2, in which I'm going to show to you now the right way to do what I showed you the wrong way to do. So I'm going to show to you the correct way to approach those patients, those cases, okay? And then on July 4th, it's wrong here, not 4th. It's on what day? Which day? Yes, 4th. The third class, yes. On July 4th. So the second class will be on July 3rd, and the third class will be on July 4th. That's it. And we still have one thing, because I know that after that exploding in your brains, you're going to need more time to think. So I'll give you just a few days so you can think about it again, and again, and then you can ask me questions. Okay? I'll be there for you. So this is the schedule. Take a screenshot. I did it wrong here. Look at this. I didn't. I'm sorry. Take a screenshot of it so you can be prepared for that. And now I need to read. Now I need to read. There's still time. Be VIP and enjoy exclusive benefits and content at the event. To further encourage this I am 5%, hashtag I am 5%, we, not I, decided to hold a giveaway for one-on-one mentorship session with me. You're going to ask me directly. We're going to be together. You can show me cases. You can show me situations like that. and I will ask questions. That's going to be a very good experience. Going to do this, give this giveaway on what day? What day is going to be that? The last day, huh?
Second class.
Oh, in the second class. In the second class, yes. In the second class, we're going to do this. If you're there, don't miss out. If you're not there and we call your name and you're not there, it's not valid. You must be there. So this is one thing that will hold you until the end. To secure a VIP ticket, follow the instructions. Visit my Instagram profile, hash Kleber Meireles Ortho, and send me a message with the word VIP. So this is going to automatically put them in the poll, okay? Is that it? Yeah. Good. I will issue your ticket and guide you on what to do to participate in the giveaway. You will need to post your VIP ticket in your Instagram stories, tagging the profile, my profile, to be eligible to this giveaway. On July 3rd, at 4 p.m. GMT UTC, check your time zone. Of course, it depends on where you live. Do you know how many countries we usually have in this type of classes? Guys, it's amazing. It's a worldwide event. I would say easily 50 to 60 countries. 130? Yeah. Come on. Yeah. 130, they're saying, what? I'm going to stay here for a longer time because I want to speak with you. Countries like, I've been to 50-something countries in person nowadays. So I have many places to go. many countries, beautiful countries in this world, this beautiful world. Okay. We'll hold the live giveaway during the broadcast of the second class. VIP ticket holders will also receive the exclusive ebook, Practice Guide to Using the Pendex. The Pendex is one of the best appliances for you to use, especially in interceptive orthodontics. I do that a lot. Cases are beautiful, cases are faster, and in this ebook I have also videos attached to it. I did some kind of changing in this ebook, but I love it. Okay, and now we are going to the Q&A. Q&A, we have also, we have already some questions. How to correct molar crossbite that forms, very good question. I'm sorry not to having addressed that before. All cases, you know that for a long time now, when we have this type of distalization of upper teeth, because of the position of the molar that makes the upper arch shorter in transversal distance than in the lower molars, when we do this type of distalization, or even when we do this type of mesialization of the lower arch, we must adapt the transverse. If we cannot do the dental expansion, we must address that by skeletal expansion. So the transverse is mandatory for taking very close attention to it. Okay? So you need to correct the transverse. This is the protocol that we use. Transverse, vertical, and sagittal. If you need to approach the transverse first, you do that by expanding with slow expansion or skeletal expansion. But very good question. Thanks for that. I can see the lower one. Extraction pattern for class 2 div 1. That's the question I had before. Do you have other questions? I also answer this one, Mauricio. This is something that we are not doing this class. But go. I can't. It's better to read the. Yeah. Okay. How to correct? Okay. How to correct molar crossbite? Okay. Already, Prof. What about canine retraction on 20 stainless steel arch wire? Are there any complications? The problem is, look at that. Why do we do the canine retraction? Usually we do the canine retraction when we have crowding. By having crowding, you don't have level, the teeth are not leveled. You need to level them before. Alignment and leveling is before that. So you can't do that using a round wire 020 in the first wire. So if you're going to do that by retracting the canine, you need to do that in a very thin arch wire because you have crowding. If you don't have crowding, you don't need to extract premolar. You extract premolar in a class 2 case when, if you don't have crowding, when we reach a rectangular arch wire. Then we do the retraction in one round. When we have crowding, we have two sets of retraction in orthodontics. The initial retraction of canine, crowding, won't make possible for you to do the 020. Ah, yes, I can do that by using bands and a passive insertion. Okay, you can do that, but you have better ways to do this. Much, much better. Three-dimensional ways to control the canine position. You can do that by loops. Loops are better. Okay, if we were to add torque with TMA wire, will it affect the sliding mechanics for space closure? I never retract. Look at this. Let me key here. I never use TMA wire to retract in sliding mechanics. I may use TMA wire to correct some torque, but when I need to retract, I need stiffness. Arch wires must be very thick, like 7-1 or 1925 at least. I usually do with 2125 in a different approach, but never ever TMA. They will not slide. They will not slide. For them to slide, you need to trim that a lot and polish that a lot. That makes the arch wire very soft. Never do that with this type of mechanics. For class 2 cases, what technique is used for desalization in preparation for unmask if the first and second molars are missing? First and second molars missing and you have a class 2. Well, you need to align the teeth that you have, the remaining teeth. You need to align, and if I would do something like that, I would, like say, in the upper arch, first and second molars are missing. We have second premolar to second premolar. A little bit of unlevelness. I will level and align, and I will do the sequence of arch wire. I will run the sequence of arch wire until I reach the rectangular arch wire, 1925. What do I do now? I will retract. What are my options? Several options. If I want to approach the vertical, I would use studs for that and use loops that I'm going to teach you. You know, this is a promise. I'm going to teach you during this week some loops that I would use for that. I have already promised that. So I would use loops with studs, or I can do a treatment planning together. I can make a treatment planning together with the implantologist, and I will tell them by 3D analysis, scanning of the arch, and CBCT, I will give to them guides so they can put the implant in position, and I will use those implants with provisional crowns to retract anterior teeth. Probably the best way to do is this one. If not, you can use studs, or you can use even 2 studs and put like a provisional crown with resin and use the same approach. So we have some options. What are the differences of the retraction of aligners compared to heavy wire? Now you're teasing me, come on. Aligners can't control the torque. During retraction, aligners can't control the torque during retraction, period. Why? Because the same point that you're doing the retraction with aligner, the way they are doing retraction with those companies, they are applying the same force that is the force that theoretically would give also the torque. The higher force will be predominant, so there's no real torque there. If we do that with 2 forces, one force outside of the aligner to retract, and use the aligner just to give the torque with thicker aligners, probably with printed aligners, directly printed aligners, we can do that. We can control better the torque. Not the way it's going, not the way it's usually done nowadays. Because this is with the sequential distalization and then retraction, not possible. Sorry for that. What are the, okay, some other questions? Come on. Are we good in time? Can we go on?
Yeah.
Can we go on? Okay. I'm good. The air conditioner is better now, huh? Sweating less now. Okay? What do we have? Still there? The question? There's no?
Yeah.
What are the difference of the retraction of a I have the same one here.
Sorry. Yeah. I'm sorry. Now we have one more. Yeah.
Okay. If I have class 2 and procline incisors, what will happen if I use 018 stainless steel? That will decrease the proclination due to the torque loss. 018, guys, is, first of all, let's think about it. What we have when we do the retraction, applying the line of action of the force at the center of the crown of anterior teeth. Let's say from K9 to K9. The line of action is approximately 10 millimeters below the center of resistance of those 6 anterior teeth. I showed you the article. There are several articles showing that. When we do that, we have just one force and one moment of the force. The moment of the force, if we apply 350 each side, 700 grams of retraction force. We have 7,000 grams per millimeter of retraction. No other force to control the inclination. What we call it is uncontrolled tipping. The center of rotation of this movement is close to the center of resistance of anterior teeth, okay? Of anterior teeth. Not mentioning that you're not really completely tying anterior teeth. It's like individual movement of incisors. So you are really doing a very bad mechanics if you can't afford 1 millimeter of mesialization of the upper anterior teeth apexes, because it's going to contact, and you may end up with root resorption and bone fenestration. If you have a very mild, very little movement to do, okay, like just closing very little diastemas, okay, that's it. Okay, sorry for that.
The last 2 questions.
Q&As, I'm sorry.
Yeah.
How to correct palatally present maxillary canines class 2 if I have class 3 with low anterior face height that needs extraction because of crowding? How can I manage facial height? You're probably asking something very specific about one case. Let me ask you something. I will give you this opportunity to send me directly this case so I can understand better, because this is a very specific situation, you know. It's not really simple for me to address all the variables that we have in cases like this, because sometimes we need to extract, but we can add some type of specific movements in orthodontics that will give us, that will provide the mechanics that you need. Extraction, this is the last one? Yeah. Okay, I'm gonna just answer this last question, and then I will close our session today. Extraction pattern for class 2 div 1 subdivision with no crowding in either arch and coincident midline. Well, I think it's not possible to have a coincident midline in a class 2 div 1 subdivision unless you have both midlines shifted. Of course not, huh? Because if you have a class 2 div 1, it means that one canine is in a different position, okay? No, there's no way to do differently unless you have like a tooth size discrepancy, a large tooth size discrepancy in one lateral, for example, in the other lateral in the lower, maybe. But this is really not possible. Pay attention to asymmetric extractions. They sometimes are very bad. I have a course on that. diagnosis and treatment planning, in which I explain how, by using the template that I created, the template that we use in this course, to understand what you can do in each case. People are not paying enough attention. You know, let me say to you something, and I want to stick that with, that sticks in your mind. You need to treat your patient like being your child, your mother, your father. So wouldn't you give some time to your mother, to your father, to your child, to just analyze better their cases and treat the proper way? So I don't ever in my life, I start a treatment without thorough analysis of the diagnosis and thoroughly treatment planning being applied to that. Never. Because after the 50s, we think we are more and more responsible for everything. I see my patients as my own kind, my own family. So that, you need to do that, guys. You need to give more time. Give more time to each case. Give more time to analyze. Give more time to do your treatment planning wherever you do. Do your own template to analyze the midlines, to analyze symmetry, to analyze the facial thirds, to analyze the pattern, the numbers, the occlusion, and what's going to happen when you do that or do this, because you owe a lot to your patients. Take that into consideration. Guys, thank you very much. Remember, class 2 will be broadcast live at 4 p.m. GMT. Of course, you need to check your time zone. This is a global event, so please check the corresponding time of the live broadcast in your time zone. Click the link, I need to go up. Click the link for class 2 in the description of this video to set a reminder on YouTube. And let me ask you again, please invite your friends to the next class. Please tell them that you will help them, because I will help you. I promise you that with these protocols. See you there. Bye-bye. Thank you.